From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm your host, Dr. Karen Lasser, Professor of Medicine at Boston University and Senior Editor at JAMA. Today, I am joined by Dr. Margot Kushel, who is a Professor of Medicine at the University of California, San Francisco School of Medicine. Welcome, Dr. Kushel, to this JAMA podcast.
Thanks so much for having me.
So to begin with, could you tell us a little bit about the epidemiology of homelessness and health in the United States?
To give you a sense of scale, on one night in January 2023, there were 653,000 people in America who are experiencing homelessness. That comes out to about 20 of every 10,000 people in the U.S. And at its heart, homelessness is really caused by the lack of affordable housing. What people see visually is often people experiencing unsheltered homelessness. Those are people who are outdoors, sleeping in tents, sleeping in their car. Whether people are sheltered or unsheltered in a community is really dependent on how much shelter there is. And one of the most important things to know about how homelessness works in this country is how deeply it is affected by structural racism. And because of that, people affected by structural racism, and then also people who have health problems that interfere with social function. So people with mental health and substance use disorders experience homelessness at much higher rates than those not affected by structural racism or without those conditions.
Now, what are some strategies to mitigate the impact of homelessness on health?
I think the most important thing is to think about it in different ways. What do we do in the healthcare system to try to improve care for people when we can't end their homelessness? This is really a mitigations practice. This is really trying to make the best of what is a difficult situation. So some clinics receive funding from federal healthcare for the homeless programs to really specialize in care designed for people experiencing homelessness. And healthcare to the homeless clinics approach really is based on having multiple points of access. So meeting people literally where they are, going out to the street, meeting them in homeless shelters, having outreach workers to go to engage to meet them in services, and then to do trauma-informed care and to have really close community collaborations so that they are working with the community efforts to end homelessness and meet basic needs, referring people to resources for subsidized housing, for permanent supportive housing, for shelters. Another really good model is in the Veterans Affairs system or the Veterans Health Administration's homeless patient aligned care teams. The VA has really been at the forefront of work on people experiencing homelessness, or specifically veterans experiencing homelessness, and their coordination with the Housing and Urban Development Department has led to a reduction in homelessness among veterans by half. But for those veterans who are still experiencing homelessness, they screen all veterans for their housing situation. They refer people who have either risk of homelessness or homelessness to resources that they have special set-asides for. And then they have these really wonderful homeless patient aligned care teams, which provide on-site, very low barrier care. You can walk in for your appointment. They really are a one-stop shop. They have showers and clothing. They have social workers there. They have mental health care as well as physical health care. And that's another really good model. Some other things that are really important parts of the mitigation strategy are something called respite programs. Respite programs provide acute and post-acute care for people experiencing homelessness who really they're set up for people who don't meet the threshold for hospitalization, but require some form of ongoing care. And there's a wide range in these programs. Some are really set aside shelter beds where people are allowed to stay during the day. which in most shelters they're not, provided with meals, and maybe a visiting nurse will come, to others that really look much more like acute skilled nursing facilities. Some hospitals, in an effort to decrease uncompensated care, will pay a per diem rate to help their patients have a place to leave after hospitalization. And increasingly, some state Medicaid programs allow for this as a billable expense.
I was wondering if you could define trauma-informed care for our listeners.
I think trauma-informed care really recognizes the myriad effects that trauma has, and it is taking every effort to not reify or replay that trauma, because health systems can be really traumatizing places. And so it is really putting the patient in control, really getting affirmative consent for everything. It is asking patients permission before you touch them in any way. It is making sure that you stop and center, and really just taking a whole range of strategies to not reiterate the trauma that people experience, and really to recognize that for people, let's say, who've had situations of abuse where they have a loss of power, where they have been in incarceration, where they have a loss of power and freedom, sometimes unwittingly, our healthcare systems can actually remind people or even replay some of those power dynamics. So it's really about shifting the power, taking care, and really making sure that the patient has full control over everything that's going on.
I think you touched on this a bit already, but can you talk some more about some best clinical practices that individual clinicians can take to improve the care experience for their patients? I think your article mentioned things like simplifying medical regimens.
I would love to talk about the things that systems can do to actually end homelessness, but really when you're an individual provider in a room, what you're trying to do is understand the difficult environmental conditions that your patient has and do things to decrease that harm. So people experiencing homelessness, things get stolen, medicines get stolen very often. So things like making sure you ask your patient, would they prefer a smaller amount, 30-day supply instead of 90-day supply with frequent refills, making it possible for them to get medications refilled when they get ruined, lost, stolen, taken away in a sweep. Doing things like giving once a day medicines whenever possible, avoiding medicines that require refrigeration, trying to set up follow-up appointments before someone walks out the door, and then being flexible on timing. If your patient is late, really doing everything you can to see them. If you have a test result pending, make sure you have a plan to get the information back to the patient and ask them, would they rather receive a text message if they have reliable access to a phone? Or do they want to come back in 2 days and actually hear what the result was? Those are just a few of the things that we can do. I would say some other things are not to assume that someone has regular access to food. Unfortunately, when people particularly are experiencing unsheltered homelessness, but any form of homelessness, they may have irregular access to food. So we might loosen our thresholds for treating diabetes to avoid the risk of hypoglycemia. We would certainly try to avoid medications that cause urination or that increase someone's need to defecate because people often don't have access to bathrooms. Doing things like that, just being aware of what people's environment are and changing your care to meet those needs can go a long way.
Could you also talk about the prevalence of mental health and substance use in this population, and if you have any recommendations for best clinical practices?
People experiencing homelessness are much more likely to have substance use or mental health problems than the general population. And I think of this as a bi-directional relationship. What informs the level of homelessness in a community is really the availability of housing that is affordable and available for the lowest income households. So communities have either high or low rates of homelessness dependent on their housing. What informs an individual's risk for homelessness within that community are often individual vulnerabilities, and substance use problems and mental health problems can really interfere with people's ability to have relationships, jobs, income, and the like. So perhaps it's not a surprise that people with those health problems are more likely to become homeless. But then homelessness is so devastating to people's health, and particularly their mental health and their behavioral health, that those problems tend to get worse. People have no sleep. People experience an enormous amount of trauma. People are really trying to cope. So that might increase someone's use of something like methamphetamines to keep them awake. And then homelessness interferes with people's access to treatment or care. I really couldn't think of a less healing environment for someone who had a mental health problem or substance use problem than homelessness, and a harder way for people to get the treatment that they need. So as a result, people experiencing homelessness are much more likely to have these problems. In our representative study of adults experiencing homelessness in California, we found that 2/3 had relatively significant mental health symptoms, although I'll add that these were primarily driven by anxiety and depression, where about half did, but 12% had ongoing hallucinations. Over a quarter had experienced mental health or psychiatric hospitalization. Substance use was really common as well. We found that 35% of adults experiencing homelessness in California reported at least 3 times a week use of either methamphetamines, non-prescribed opioids, or cocaine. This was mostly driven by methamphetamine use. 31% reported regular use of methamphetamines, 11% non-prescribed opioids, most of whom also use methamphetamines, and 3% cocaine. And 9% reported heavy weekly alcohol use. So really heavy episodic alcohol use or binge drinking 6 or more drinks in one sitting at least once a week.
Yeah, that's significant. Switching gears a little bit, could you tell our listeners about the principle of housing first?
I think this is one of the most important things for the healthcare community to know about. Housing First was really developed in the early 1990s through the Pathways to Housing program. And what it is the principle that housing should be offered without preconditions of engagement in treatment or without time limitations, meaning that the best way to get someone housed is not to insist that they go, let's say, to mental health treatment or substance use treatment, or to give them an 18 months to sort of end their homelessness, but rather to put them in a form of subsidized housing, but then to link it with robust supportive services, such as case management, substance use and mental health care, vocational services, medical care. In Housing First environments, people need to meet the criteria of a tenant, meaning if they're expected to pay 30% of their income on rent, which is usually what is required in subsidized housing, they certainly have to adhere to that, and they had to adhere to basic tenancy rules. But what they don't have to do is prove that they're sober, let's say, or taking psychiatric medicines before going into housing or as a condition of housing. What research has found in several robust randomized controlled trials is that this is a very effective method to get people housed, to keep people housed, and people in that housing, when services are offered on a very low barrier way, tend to take up those services. So for instance, a randomized control trial of over 2,000 people experiencing chronic homelessness, prolonged homelessness, who had severe mental illness, compared those people to similar ones of 1,100 people who were randomized either to Housing First or to treatment as usual. And what they found was that 73% of those randomized to Housing First remained housed at 2 years compared to 32% in usual care and did overall better. Our group did a randomized controlled trial among chronically homeless individuals who had very high use of public systems, jails, psychiatric hospitalizations, and randomized them to permanent supportive housing with services delivered by a team, which was made up by a master's trained behavioral treatment provider, like a licensed social worker, a peer, and a bachelor's trained case manager. Those three staff would have 45 clients. And what we found was prolonged engagement in housing. So by the time we finished the study, over 91% of people randomized were housed. They remained housed for over 90% of their nights for many years. And those randomized to this program wound up with lower rates of psychiatric emergency department use and higher rates of ambulatory mental health services compared to control.
One other question is, what is the mortality rate among people who are experiencing homelessness relative to those who are not, and what plays into that?
As a measure of the incredible danger and devastation of homelessness, homelessness is associated with dramatically increased mortality rates. The relative rates compared to the general population really depend on the age of the people experiencing homelessness. Nearly half of single homeless adults, those are people experiencing homelessness over the age of 25 without a child with them, are now 50 and older. There was a large cohort study done of adults seen at Boston Healthcare for the Homeless program. So these were individuals who were homeless during one point in their life, and many continue to be homeless, found that for men and women experiencing homelessness between the ages of 25 and 44 were 8.6 and 9.6 times more likely to die than those in the general population. And 45 to 64-year-olds were overall 4.5 times more likely to die, 3.6 for men and 5.6 for women. In our study of people who were 50 and older and experiencing homelessness in Oakland, we found that overall there was a 3.5-fold increased risk of death, age-adjusted increased risk of death. It was about 3.1 for men, 5.5 for women. For those people over 50, the leading cause of death was cardiovascular disease and cancer. In those overall in the homeless population, the leading cause of death is drug overdose.
I believe your review also talked about the higher rates of cigarette smoking in this population as well.
Absolutely. Cigarettes smoking and tobacco smoking is extraordinarily high in people experiencing homelessness. And there are really needed efforts to reduce that, because this winds up being a major cause of morbidity and mortality. In our study in California, which has very low rates of smoking as a state, 54% of adults experiencing homelessness were daily smokers. In many studies of people experiencing homelessness, 70 to 80% engage in cigarette smoking. And other research has shown that smoking attributable diseases contribute a large proportion of the excess mortality.
Yeah, it's staggering. Well, my final question is there anything else generalists should know about healthcare for people experiencing homelessness that we haven't talked about?
I think the main thing that generalists should know is, one, it's important to know whether your patient is experiencing homelessness or at risk for it, because its impacts are so protean that it really affects every aspect of their care. Remembering to do those mitigating things, allowing people to be late for their appointment as much as you can, trying to do everything at once, give them those vaccines that day, making sure that people have medications that they can get refilled, because medicines are often lost and stolen, not requiring medicines to be refrigerated, so avoiding medicines that need refrigeration, being careful about side effects and things. But also, I think it's really important that we know our community resources, that we refer people to homeless services and housing resources in the community, that we refer them to legal services if that's what they need. And I would add that it is really important for us as healthcare providers to speak with one voice. One is to push back on this individual narrative. We know that we can care well for people who have a variety of health problems, including substance use and mental health problems, and that these are not moral problems, but really complex problems that have biological roots and environmental roots and are responses to trauma, and problems that we can actually help people thrive with. We just struggle to do that when they're homeless, to really speak out about the ways that homelessness impacts people's health and to speak out for the need for real solutions that adhere to what is really a very strong evidence base.
Thank you so much. This has been tremendously helpful. I'm Dr. Karen Lasser. I've been speaking today with Dr. Margot Kushel from the University of California, San Francisco, about healthcare for people experiencing homelessness. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.